Now, some more points about atrial fibrillation. As the patient presented to us with palpitations, now in atrial fibrillation, other than managing the clot formation through anticoagulants, the other thing that we need to treat is heart rate or rhythm. Because the patient heart rate is very much high in atrial fibrillation, and also the rhythm is not sinus rhythm because there is no PV, and the rhythm is originating from somewhere else other than SA node. So that's why we need to address these two issues as well. Now, before discussing the management or the management of heart rate and mm, rhythm conversion, we'll discuss some points, important points, or important factors which favor rate control and factors which favor rhythm control. Though the chances are very less likely that uh, uh, they will ask you question about rhythm control in lab 1, or they will ask you about when to go for rate control or when to go for rhythm control. But still, you should know that when we should opt for rate control and when we should opt for rhythm control. So, if the patient is older than 65 years old and he has a history of ischemic heart disease and the onset of atrial fibrillation is more than 48 hours, or we don't know the onset of atrial fibrillation, or the onset or the time duration is uncertain, then if these three factors are present, which is age more than 65 years, history of ischemic heart disease, and onset is more than 48 hours, or we are not sure about the time duration, then we will uh, try to adopt a rate control strategy. But if the patient is younger than 65 years and he is symptomatic and it's a presentation, or he has sign and symptom of congestive heart failures, or if it's atrial fibrillation without any heart disease, or atrial fibrillation secondary to alcohol use, then we'll adopt a rhythm control strategy. So in older patients with history of ischemic heart disease, rate control strategy. In younger patients, symptomatic first presentation and sign and symptoms of congestive heart failure, then we'll adopt a rhythm control strategy. Now we are going to discuss one by one some drugs which we can use to control, which we can use for rhythm control strategy and rate control strategy as well. So you need to remember two drugs which can be used for pharmacological cardioversion or rhythm control. Cardioverting the patient rhythm to sinus rhythm. Which pharmacological drugs can be used for rhythm control? You only need to remember these two drugs, amiodarone and flecainide. These are anti-arrhythmic drugs which can be used for rhythm control strategy or for pharmacological cardioversion in atrial fibrillation. While for controlling rate control strategy, if we are opting for rate control strategy, then we'll opt for beta blockers is the first line, unless the patient has asthma, because beta blockers are contraindicated in asthmatic patients. So if an asthmatic patient present to you with atrial fibrillation, to control the rate, we'll use calcium channel blockers. Cardioselective calcium channel blockers such as diltiazem and verapamil will be used in place of beta blockers if the patient is asthmatic. And the third drug which can be used for rate control in atrial fibrillation is digoxin. If the patient has a coexistent heart failure. So beta blocker is the first line if there are no comorbidities. Calcium channel blocker if the patient is asthmatic, and digoxin for rate control if the patient present to you with heart failure. So for rhythm control, what are the indications for rhythm control? The indication for rhythm control is old age patient older than 65 years, history of ischemic heart disease, and onset of arrhythmia is more than 48 hours ago, or time duration is uncertain. Then we'll go for rate control strategy. And the drugs that can be used is beta blockers, calcium channel blockers, and digoxin. In patients who are younger than 65 years and they are symptomatic or have signs and symptoms of congestive heart failure or atrial fibrillation secondary to alcohol intake, then we will go for rhythm control strategy and we will use amiodarone or flecainide. Can any one of you tell me amiodarone is used for the management of which other arrhythmia? Which other arrhythmia is managed or by amiodarone?
Ventricular tachycardia.
Yes, excellent. Ventricular tachycardia. If hemodynamically stable ventricular tachycardia, also this is the principle in atrial fibrillation. If patient presents to us with a hemodynamically stable atrial fibrillation, then we can use amiodarone for cardioversion. Amiodarone or flecainide will only be used if we are adopting a rhythm control strategy. Otherwise, we will use beta blockers, calcium channel blockers, or digoxin. Don't forget this point. As I have told you in the previous lectures that any arrhythmia in a hemodynamically unstable patient will be managed by cardioversion, electrical cardioversion, and not pharmacological cardioversion. Either it's VT or it's atrial fibrillation, and the patient is hemodynamically unstable, i.e., his systolic blood pressure is less than 90, then electrical cardioversion will be used. And stable arrhythmias are managed by pharmacological cardioversion. So don't forget this point. So this was all about the management of atrial fibrillation. So a short summary for the management of atrial fibrillation is that the diagnosis is made on ECG. Two important points for the diagnosis of atrial fibrillation is absent P wave and irregular QRS reflexes. And then acute management include rate control and rhythm control. Rate control is done in old age patients who are older than 65 with a history of ischemic heart disease. And if the onset of atrial fibrillation is more than 48 hours, then rate control strategy will be adopted. Beta blockers, calcium channel blocker, and digoxin is used for rate control. And for rhythm control, amiodarone or flecainide can be used. Also, the long-term management of atrial fibrillation include anticoagulation in the form of direct-acting oral anticoagulants such as cepaxiban, rivaroxaban, and if it's contraindicated or if the patient cannot tolerate direct acting oral anticoagulants, then we can give warfarin as an alternate. Is it clear to everyone up to this point?
It's DC cardioversion
Is
and
there any question?
electric cardioversion. They are both
DC
same.
cardioversion.
So is the electric cardioversion. They are both same.
Yes, DC cardioversion and electric cardioversion are same.
Okay.
For all the arrhythmias, if we want to use electrical cardioversion, that will be DC cardioversion. And only for fibrillation, we use defibrillator or defibrillation. There is a slight difference between defibrillation and DC cardioversion. In DC cardioversion, the amount of current is used is usually low, such as 50 joule of shock is given, while in defibrillation, the amount of current that is used is high, almost 200 joule shock is given to the patient. So here's another ECG of atrial fibrillation. You can see at the bottom of the picture here that you cannot see, you can see a T waves here, 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 and here, but you cannot see any P wave. There is no P wave present. And the QRS complexes are also irregular. You can see that two small boxes, two small boxes, two small boxes, two, here is 2.5, two, again 2.5, 1.5. Here you can see it's almost one, two, three large boxes. Here it's 1.5 large box, here 1.5 as well, here and well, here too. So irregular QRS complexes and absent P wave.
So will it be spread all over in all the leads of the ECG or in
Remember
specific?
that whenever you are going to diagnose an arrhythmia, you will look at the rhythm lead. You can see that 12 leads are given here, but at the bottom of the ECG, always a rhythm lead is given, which is usually lead number 2. Limb lead 2 is used as a rhythm lead. The rhythm lead is usually 10-second longs. So to diagnose arrhythmia, you will look at the rhythm lead. Though you can find this abnormality in some other leads as well, but the correct or accurate way to diagnose an arrhythmia is to look at the rhythm lead, which is usually given at the bottom of the ECG.
Okay.
So normally, how we calculate heart rate from an ECG? What is the method to calculate heart rate in an ECG? That we calculate the number of large boxes between two R waves and divide it on 300. So 300 divided by number of large boxes between two R waves. In a normal ECG, we calculate the heart rate by counting the large boxes between two R waves and divide it on 300. For example, let's suppose there are three large boxes between two R waves, then 300 divided by 3, our heart rate will be 100. So the number of large boxes between two R waves divided by 300, sorry, 300 divided by the number of large boxes Yes, 100. Now, if the patient is having tachycardia and his heart rate is very fast, then we will calculate small boxes. The number of small boxes between two R waves. Let's show you an example. This often. And in regular mapping, this now let's calculate the heart rate in this ECG, just as an example. Remember that we calculate heart rate and rhythm, and we see the rhythm in rhythm lead, which is given at the bottom of the pic. But here, just for some practice, we'll calculate the heart rate from lead V6.
Excuse me,
So,
sir.
yes,
Sir, the questions for the heart rate, they can be asked in play for
no,
calculating
they
heart rate.
will not be. They will not be asking the plat. This is just for your knowledge.
Okay, sir.
Because if a patient present to you with arrhythmias, then to see if the patient has a tachycardia or increased heart rate, you will need to calculate the heart rate. So that's why it's important to know how to calculate heart rate from ECG. But there will be no direct questions about calculating the heart rate from ECG. So
Okay.
can anyone tell me the number of large boxes in lead V6 between two R waves?
4. No, sir.
One,
Between
two,
two R waves.
yes. Between two R waves, what are the number of large
It's
boxes?
It's 4.
Yes, the number of large boxes between two R waves is 4. So 300 divided by 4, what's the answer?
75.
75. So the heart rate is 75. Now, if the patient is having a tachycardia, like here, is a torsid depointes, which is a tachycardia as well. See, just as an example, you cannot calculate the number of large boxes if the patient is having an increased heart rate or if the patient is having any kind of arrhythmia. So in these kind of scenarios, we will calculate the number of small boxes. Like here, you can see that here we will calculate. You can see that between two R waves, there is only one large box and one or two small boxes. So to calculate heart rate accurately in such kind of situation, what we'll do, we'll calculate the number of small boxes and divide it on 1500. Suppose the number of small boxes between these two RR interval is one large box is equal to five small boxes, so 5 and 6. So almost 6 small boxes between two RR waves. So what is the heart rate? 1500 divided by 6. What is the answer? 1500 divided by 6. 6 2s are 12. Yes, almost 250. So far we have discussed two methods to calculate heart rate. Normally we calculate heart rate by counting the number of large boxes between two R waves. So 300 divided by number of large boxes between two R waves. And if the person is having tachycardia, then we'll use the other method, and that is to calculate the number of small boxes and 1500 divided by number of small boxes. So both these methods are clear to everyone.
Sir, 300 by number of large boxes in normal situation. And if
Yes.
tachycardia, then 300 by number of small boxes, right?
No, 1500 divided by number of small boxes. Yes, that's right.
Sure. Okay.
Is it clear to everyone else? So what are we gonna do if the patient is having an irregular QRS complexes? Then what is the method to calculate the heart rate if the patients, like in this ECG, and the RR interval are irregular? So we cannot, how we are gonna choose that from between the two R waves, we are going to calculate the small boxes or large boxes. In these kind of situations, we calculate the number of R waves in a 10-second strip. The rhythm strip is usually the rhythm strip that is given at the bottom of the picture, usually is 10-second long. So we will calculate. So in case of atrial fibrillation, the method to calculate heart rate is different. How it is different? In case of atrial fibrillation, we will calculate the heart rate by counting the number of R waves that are present in a 10-second strip. For example, how many large boxes will be present in a 10-second strip? One large box is equal to, this one large box is equal to 0.2 seconds. 0.2, 0.2, 0.2. So five large boxes are equal to 1 second. 5 large boxes are equal to 1 second. How many large boxes will be equal to 10 seconds? Anyone? If 5 large boxes are equal to 1 second, how many large boxes will be equal to 10 seconds?
50?
50 large boxes. 50 large boxes. So a 10-second strip contain 50 large boxes. So now can anyone count the number of large boxes in this strip that is given at the bottom of this ECG? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 15, 20. There are almost 50 boxes. So it's confirmed that the rate relations count the number of R waves in 10-second strip. So we'll count the number of R waves in 10-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 19 R waves in a 10-second strip. Now multiply the number of R waves with 6 to make it a heart rate in 1 minute, because we have counted the number of R waves in 10-second strip, so we need to multiply it with 6 to make it 60 minutes. So the number of R waves will be multiplied with, yes. So heart
Sorry,
rate
I'm not
in
getting
case
that.
of atrial
Can you
fibrillation.
can you explain that again, please? It's not. I'm not getting.
You need to calculate the number of R waves that are present, and usually, normally, the standard method, or in a standard ECG, the rhythm strip that is given at the bottom of the ECG, like here, it is 10 seconds long. So now let's calculate the number of R waves in this. Calculate the number of R waves. They are 19 R waves, and multiply the number of R waves with 6. So the number of R waves in a 10-second strip multiplied by 6. Is it clear now?
So initially, like the what the strip, if it is 10 second and each live box is equal to 0.2 second. So how it makes like 50 large boxes? Do we multiply 0.2 with 10?
50 large boxes. That was just a way of confirming that it's a 10-second strip. Usually at the bottom of the ECG, the rhythm strip is given, which is 10 second long.
Right.
So normally, one large box is equal to 0.2 second.
Mm-hmm.
So a 10-second strip will be 50 large boxes long,
Right.
because 50 multiplied by 0.2 is 10.
Yeah, that's fine.
So we always need to calculate number of R waves in a 10-second strip and multiplied it with 6 to calculate heart rate in atrial fibrillation. Is that
Yeah,
right?
got it now.
Dr.
Yeah,
Sombal,
that's fine.
Dr. Shavraz, and Dr. Anjo? Is it clear to all of you?
Yes, sir.
So with 19 large boxes,
Shavraz, I didn't.
what would be the rate in that case? Do we multiply 19 by 6? multiply
There are 19.
19 with 19 R
Yes,
waves.
multiply 19 with 6. The number of R waves will be multiplied with 6. Dr. Musharraf?
I'm saying why we multiply with 619, why we multiply with 6?
Multiply with 6 because no, we have multiplied with 6 because we have calculated the or we counted the number of R waves in a 10-second strip, and we need to calculate the heart rate for 1 minute. So that's
Okay,
why
so you
10
for 1 minute.
seconds multiplied 6 is 60 seconds. So
Yeah,
to calculate heart rate per minute, we multiply it with 6. That's the
okay,
reason.
okay, that's fine. Got it now.
So we are done with how to calculate heart rate. Making it clear in this lecture because there will be no separate class for ECG to save our time, because I want to cover maximum chapter before FAB exam, because 3 or 4 people of you have exam on 17 February. So we were discussing atrial fibrillation, and we are done with atrial fibrillation. So an elderly patient fell and collapsed. He was transferred to accident emergency and now he's fully conscious. ECG shows irregular rhythm. What's the best investigation? So ECG is showing irregular rhythm. The next best investigation would be echocardiogram. If arrhythmia is diagnosed on ECG, then the next investigation will be echocardiogram. If arrhythmia is not diagnosed on ECG, then the next investigation will be a 24-hour ECG or a Holter monitor ECG. The most common valvular heart disease is aortic stenosis. To and what can relation vibratory cardio, both of them can cause atrial fibrillation. Constrictive pericarditis can cause atrial fibrillation. Hyperthyroidism can cause atrial fibrillation. Excess alcohol intake can cause as well. And female with a history of atrial fibrillation, accident emergency, and asymmetric weakness of face and arm. These symptoms started 3 hours ago. CT scan of the head shows no hemorrhage. The long-term management of this patient would involve. So, can anyone tell me what will be the long-term management of this patient? Which medication will this scenario?
Direct acting anticoagulants.
Just direct-acting anticoagulants. Any other medication?
Also, also for
Also,
controlling rate and rhythm.
for controlling long-term medication, rate and rhythm Uh, Rhythm is usually we have discussed that uh, we'll go for rate control strategy or rhythm control strategy if the onset of symptom is less than 48 hours.
Altiplase.
Altiplase is used in the management of stroke, but that is an emergency treatment of
So this
stroke.
is like a she had a weakness of FSNM and
Clopidogrel and
there is no hemorrhage.
no,
So it's
Yes,
like
there's
statins and clopidogrel.
statins and clopidogrel are long-term medication in patient stroke, but if the stroke is with atrial fibrillation, then long-term medication will be acting equivalents and stents. So remember this
Statin.
if stroke is
Okay.
without atrial fibrillation, then the long-term medication will be statin. Has a history of atrial fibrillation and she has developed stroke, so the long coagulants and stents. So